individualised risk assessment in 10 minutes. So we have an infographic in the pack for you on this. As I mentioned earlier, this is one of the ones that I was really surprised we didn't see a much bigger improvement in nationally this year. And I think that's because there are still some controversies out there, and I'm hoping to put two of them, I hope, to rest at least temporarily. So this is what the infographic looks like. And just to cover the background, individualised risk assessment, we think, is a really important thing from a patient perspective, holistic perspective. It's the right thing for the patient. It enables us to begin the process of shared decision making. It is only the beginning of that process. And you've already heard just now in the case of diabetes, we've also heard this morning around things like anemia, pain management. It's with that individualised risk assessment at the beginning that the pathways for all of those difficult problems start. So if you identify patients who you think are likely to have a problem with pain later at the preoperative assessment stage, then it's likely that you'll be able to set them on a path that means that their pain outcomes won't be as bad as you anticipated they might have been. But I'm going to focus on risk assessment from the perspective of predicting patients who are likely to have morbidity or mortality. If it wasn't a good enough reason to do it from a holistic, patient-centered perspective, there is a legal imperative now because of the Montgomery ruling. And I'm sure by now all of you know about this case, but essentially Nadine Montgomery, who was a woman who was diabetic and of short stature and presented in labour, and she went on and had a normal vaginal delivery and a shoulder dystocia with a baby that then had cerebral palsy as a result of that. And the shoulder dystocia was well managed, but the thing that was criticised was the fact that because of her history, she was much, much higher risk of this particular problem than the average population. So in her case, population percentages were not good enough. It was the individualised risk assessment to her that should have happened. And as a result of that, she was awarded a lot of money. That's not the point. The point is that the law has changed in order to reflect this. And so we are required to do this. So what are the dilemmas in risk assessment that might be preventing us from implementing this in practice? Well, there are lots, but I'm just going to cover two because we're short of time. So the first is whether we, as clinicians, are good enough, or whether we need to use some sort of widget, whatever that widget might be, in order to help us risk assess our patients. And the second is, if it is a widget, what sort of widget should it be? Should it be an assessment of functional capacity, or should it be a risk calculator? So if you are going to assess a patient for prehabilitation, so this is for potentially for optimization of fitness, specifically physical fitness before surgery, then there is a particular approach that might be required for that. This study was published last year in The Lancet. It was published since last year's PQIP report came out, and we waited for it eagerly. And it compared N-terminal proBNP, which you will know is a plasma biomarker, the Duke Activity Status Index, which is a patient self-completed questionnaire about what they're able to do in terms of fitness and activity, with clinician judgment and cardiopulmonary exercise testing. And this is the main results table, and I appreciate that this won't project brilliantly, but in terms of predicting 30-day death or myocardial infarction, the best predictor was a combination of using cardiopulmonary exercise testing data and the Duke Activity Status Index. And for predicting longer-term mortality, the combination of all three of those gave an area under the receiver operator characteristic curve of 0.72. Now, that's not overwhelmingly exciting in terms of an area under the curve. For a predictive test to be really, really accurate, we would normally look at, in terms of discrimination, something that had an area under the curve of at least 0.8 or higher. But what we do know from these data, which is really critically important, is that clinicians are absolutely no good at assessing patients' physical fitness. And that's not necessarily our fault. If we ask a patient, how many flights of stairs can you walk up? We don't say, how many flights of stairs can you walk up in 30 seconds? We say, how many flights of stairs can you walk up? And therein starts to lie the problem about the patient not quite telling us the information that we think that we're hearing. So if you want to objectively measure functional capacity, we need to ask patients to do something objective, and that might be filling in the Duke Activity Status Index, or it might be putting them on an exercise bike. And that is the clear take-home message I took from this paper, and that is why I think that those methods are really important when you are thinking about selecting patients who might benefit from preoperative exercise interventions. Now, for the majority of patients, for one reason or another, partly because the pathways aren't necessarily in place in every hospital at the moment, as we heard during the panel discussion earlier, preoperative exercise training or prehabilitation in any form is not necessarily something that's going to be offered to every patient. So in terms of individualized risk assessment, we might just want to focus on those patients that are high risk in terms of their mortality or morbidity risk, so that we can do a number of things, such as decide which patients might benefit from critical care after surgery, which patients might benefit from other specific targeted interventions, whether we might, for example, modify the type of surgery that the patient's having from a higher risk procedure to a less severe procedure if they're very high risk, and so on and so forth. So we did a study which many of you will have been involved with, the SNAP2 EPIC study, which was led by Danny Wong, our trainee lead, and a number of other collaborators. And the main results manuscript, the results I'm going to present to you now are in submission with a journal at the moment, so they're not published, but I hope that the journal's not going to make us change the results too significantly. So these are calibration plots, A, B, and C, and ROC curves for 3 commonly used risk calculators. The PPOSM everyone will have heard of, the Surgical Risk Scale, SRS, and the Surgical Outcome Risk Tool. And you can see, the anaesthetists in the room will be used to looking at calibration plots, but essentially you want the calibration plot to be as close to that line going up the centre as possible. And you can see PPOSM's way, way out, SRS pretty far out, and SORT's a bit better, but is out towards the higher ends of risk. So of the 3 in terms of calibration, as in if it's a 1% risk, is it really a 1% risk, or is it a 10% risk, or a 3% risk? The SORT is the best, but it's not perfect. If you look at area under receiver-operator characteristic curves, you want a really good risk prediction model to have something that goes straight up the left-hand axis and straight across the top. And you can see, of those, the SORT is the one that achieves the closest to that. And if you compare it to clinicians, on the left-hand side is the calibration plot, so we're real pessimists. We think that everyone's going to do much worse than they actually turn out to do. I should remind you that this was a cohort of 26,000 patients recruited from 274 hospitals in the United Kingdom, Australia, and New Zealand. So this, I think, really is genuinely reflective of real life, real clinicians trying to predict risk for real patients, and we are pretty pessimistic. However, when it comes to calibration, when it comes to discrimination, we're not bad at all. We line them up in order of risk reasonably effectively. If you look at area under the curve and compare those 3 different methods, clinical judgment on its own, the SORT, which was the best of those objective tools, and a model that we created which combined information from both of them, the higher the number, the better. Basically, the SORT and clinical judgment are roughly equivalent. If you combine the 2, which we will do in an updated calculator, once the peer reviewers are finished with this, we'll republish the SORT calculator with clinical judgment in this. Combining the 2 means that you achieve the highest, best possible prediction of 30-day mortality that it is possible to do using these methods. Very, very highly accurate, nearly 0.93. And it's significantly better than using either method alone. So we've got to just make this happen now. The bottom line is, if you're going to try and risk stratify patients for prehabilitation, you need some sort of objective measure, like the DARSI, like an exercise test. But if you are trying to stratify patients in terms of their 30-day mortality risk to try and work out what to do with them when they're in hospital, the SORT is really, really easy. It's 6 variables, it's free, and you can do it at any point during the preoperative pathway because it doesn't require blood tests. So really then it's a question of just making it happen. So we need to think about our preoperative pathways. The referral starts with the surgeon at the time that he or she sees the patient in the clinic and decides they need an operation, or in the multidisciplinary team meeting where everybody's reviewing the radiology and so on. So actually, the only skill that is required to calculate the sort is the skill to be able to make an ASA grading, which does require a little bit of training. But aside from that, it's a very, very straightforward calculator to use. So can we get it implemented at MDT clinics or at the time of surgical referral? Because if we can do that, and a patient is predicted to be greater than 1 or 2% risk of death, that's the point that you then activate a pathway in your own hospital which sends the patients down to see a high-risk preoperative assessment clinic or to see a nutritionist or to think about modifying their surgical procedure or sending them to ITU, whatever the local setup is. And all of this, of course, depends on timing preoperative assessment as early as possible in the pathway in order to actually be able to affect useful change. So that's the infographic which summarises everything that I've talked about. Thank you.